Good day. It's my pleasure on behalf of Catheterization Cardiovascular Interventions to welcome Dr. Mike Kutcher to our conversation. Today we're going to talk about their manuscript that was chosen as the editor's choice for the January issue of Catheterization Cardiovascular Interventions. They discuss comparative effectiveness of drug-eluting stents on long-term outcomes in elderly patients treated for in-stent restenosis, a report from the National Cardiovascular Data Registry. Michael, welcome. Maybe you could tell us a little bit about this important and interesting investigation.
Thank you, Steve. It's great to be here and to have a discussion about our study. This was part of the Federal Agency for Healthcare Research and Quality, or what's called RQ, and it was a particular grant that Pam Douglas at Duke got, which is called the DECIDE study, and that is developing evidence to inform decisions about effectiveness. And this is really a long-term outcome study, and it's part of a panorama of long-term outcomes that have been generated from the NCDR FSCAI Registry, utilizing a very unique CMS data link, whereas the in-hospital data is then linked with long-term billing data from Medicare, and that gives information as to what outcomes occur with patients. I was privileged to lead this team. This is one of many teams of the DECIDE study, and this study, of course, as you indicated, is on in-stent restenosis. Pam Douglas was magnificent as the leader of this and very generous in allowing many individuals to work on this. The writing team consisted of John Messenger, who was the liaison for the NCDR, and we had this terrific group at Duke with Matt Brennan and Sunil Rao, David Day, who is our statistician, Kevin Angstrom, and Michael Booth. We also were joined by Nowar Mustafa from Christiana Healthcare in Delaware, and Art Sakarian from Cornell. And it was just a terrific group, and I was just honored to be given the lead on this. But everybody heavily contributed to this, and it was a really fun project to do.
Well, I think it really shows the opportunity for the cardiology community to come together.
Well, I'm a basic interventionalist, Steve, and technique and oriented, but working with the NCDR has been a great experience. It allows one to work with a skilled team and to develop different concepts and look at different ideas. This is a tremendous resource to look at contemporary cardiology practice. We'll just go into the details of this study. The big issue was the conundrum of in-stent restenosis, which, as you know, in the early 2000s with bare metal stents was about a 30% incidence, and was notoriously difficult to treat. In fact, you and I remember the course of vascular brachytherapy and all the machinations we have to go through with that. And with the advent of drug-eluting stents, the restenosis rate was reduced to 10%, but it still occurs. And what to do with in-stent restenosis. And about the same time in the early 2000s when drug-eluting stents came out, there was the concern about late stent thrombosis. So putting all this together, the background of in-stent restenosis and what you do about this, and to look at treatment modalities and trends. So we looked at the NCDR FSCAI Registry from 2004 to 2008. Now this encompasses about 90% of the first generation stents. So if there was concern about late stent thrombosis for in-stent restenosis, we thought we would see this. We also thought we'd see a lot more vascular brachytherapy. And even though the scissors and the Taxus 5 ISR articles came out in 2006, and this was 2004 to 2008, there was very little vascular brachytherapy used. In fact, the therapy really boiled down to drug-eluting stents or bare metal stents or a balloon angioplasty. So we had a record of 1.7 million patients who were treated with PCI during that course of time. And of this, 162 patients had in-stent restenosis, and of this group, 76,000 were beyond the age of 65. And of these, 43,000 we were able to link with this CMS database and look at the primary endpoints of death, myocardial infarction, revascularization, stroke, and bleeding. And we looked at in-hospital outcomes and then also long-term hospital outcomes up to 30 months using this CMS data link. We looked at both unadjusted outcomes and then adjusted outcomes. We used a propensity score match for the adjusted outcomes out to 30 months, and also an inverse proportionality weighting to try to make this as fair as possible. What we did see was with unadjusted outcomes that the drug-eluting stents were done in more stable patients. They weren't done in acute MI, whereas bare metal stents were. So to be fair, we tried to do this adjustment and determine the outcomes. What we found is that when we compared drug-eluting stents versus bare metal stents, that by propensity matching, drug-eluting stents had lower death, lower MI, and lower revascularization rate. When we compared drug-eluting stents versus balloon angioplasty, again, there was a low incidence of death and a low incidence of revascularization compared to balloon angioplasty. And when we compared balloon angioplasty to bare metal stents, there was really no difference in these primary outcomes. So one of the biggest messages of this is that drug-eluting stents reduced 30-day adverse outcomes, particularly mortality. And if you remember, in that course of time, it wasn't until the Curtani article came out that we saw that there was safety in using drug-eluting stents in high-risk patients. We also did not see an increase in ST elevation MI in the drug-eluting stent patients. And the bleeding and stroke was not increased in drug-eluting stent group compared to bare metal stents. And that balloon angioplasty compared very well to bare metal stents, and there was no particular difference in outcome. So what this really boils down to is that it is safe to use drug-eluting stents even in an elderly population where you may be concerned about bleeding complications, you may be concerned about compliance with medication, and this reaffirmed the safety and effectiveness of drug-eluting stents in this particular subgroup of in-stent restenosis.
Well, you know, I think there's so much information here that you provided, and part of that is due to this unique linkage that you have. Certainly, if we tried to design a study with this number of patients without using this unique database, we wouldn't have been able to do that. And it is answers that we, in our individual practice, would like to know. Is it safe? Can I do that? What's the best approach for these patients? And hopefully it'll help shape not only our individual practice, perhaps systems approach as well. I know that one of the issues that our readers and those watching this are going to say, how can I do that? Look at this great work that Mike and the others have done, but is that something that I could do? You know, I spend the time and energy entering patient data, but how could I ask that kind of question? Maybe you could help us understand that.
Well, Steve, the NCDR has been very proactive about trying to include all its members, those that contribute to the NCDR. So it doesn't go into a blind vacuum. And the message I want to give out there is it's not just for a select group of people. There's a research and development, a research and publications committee headed by John Messenger, that if an individual out there is interested in a particular question, they can petition this. There's a form to fill out, hypothesis, statistical analysis, and they can submit this to the Research and Publications Committee. The committee meets every quarter, and there's a group of about 10 individuals that review each of these protocols, and then there is a grading system as to what would be most appropriate. And if a particular protocol or study seems to have high grades, then the NCDR will provide the resources such as the Duke Research Group, the Mid-America Heart Institute, and you can then work with this group. Or if you're interested in participating in a particular project, you can also petition the Research and Publications Committee that you may want to be involved in one of the writing groups. This can be found on the NCDR CAP-PCI Registry page, and I encourage everybody to think about this if you have an interesting question. It's a great group of people, and again, it's not a black box, and it's not just a select few. It's open to everybody. I mean, look, they even accepted me.
Exactly, yeah, somebody like yourself, who's an icon in the area. I think we would be remiss if we didn't acknowledge the fact that this database really began with SCAI roots, that it started within our own organization.
Outstanding. Ron Krohn and a number of individuals really developed the original database. And when the American College of Cardiology decided to support the concept of the National Cardiovascular Data Registry with the encouragement of Bill Weintraub and then Ralph Brindis, that Ron and his group were there, and wholeheartedly, we already had a core of this. So SCAI has been the foundation of what then evolved into the NCDR. And I want to give recognition to Ron and all his colleagues and those individuals in SCAI who worked with this particular database back in the late 1990s or mid-1990s, I think.
Well, on behalf of catheterization and cardiovascular interventions, this kind of manuscript really helps with clinical practice. We look forward to the process of data mining, if you will, and collaborating between NCDR and CMS for longer-term outcomes. I think there really is an opportunity that we haven't had until this kind of an effort that Pam Douglas has led. And I think the payoff for that is going to be our ability to really answer more specifically how to care for patients. So thank you and your team for sharing that. Congratulations on a great manuscript. I know we're going to see more coming out of the group, with your leadership in particular.
Thank you, Steve. It's been great talking with you and great to connect with the colleagues out there who may be reading this manuscript in the near future.
All right. We look forward to seeing more of it. Thank you again, Michael.
Thanks, Steve.